Hi there, welcome back. So this time, let's try to answer the different ABGK problems that I gave you, okay? So look at your number one, pH is 7.48, PCO2 is 39, bicarb is 30, okay? So I hope you are familiar now with the different values. Now with your pH 7.48, remember the normal pH is 7.35 to 7.45. So definitely 7.48 is high. 39, remember the normal carbon dioxide is 35 to 45. So this is normal, okay? Bicarbonate is 22 to 26. This is high. So what do you think is this result? Your answer must be metabolic alkalosis uncompensated. So this will be metabolic alkalosis uncompensated. Uncompensated. Why metabolic alkalosis? Remember, the pH is high, bicarb is high. Remember that bicarbonate is alkaline. If there's too much bicarbonate in the body, the pH increases because an increase in the pH is alkalosis. Now, what makes it uncompensated is your PCO2. Your PCO2 didn't do anything. Your PCO2 is normal. Should there be compensation, your PCO2, your carbon dioxide, should increase. Why is it important for the carbon dioxide to increase? Because if there's increased carbon dioxide, it decreases the pH, causing acidosis. In short, this condition is metabolic problem, but your respiratory system did not do anything. Remember, in your video clip number 1, I said there are two systems that will regulate the pH. You have your respiratory and your urinary. If one system is not doing well, the other system will kick in and it will compensate. In this condition, it did not compensate because the PCO2 is still normal. Okay? So this is your metabolic alkalosis uncompensated. I hope you got it correctly. Let's proceed to your situation number 2. Your pH is 7.33. Again, the normal pH is 7.35 to 7.45. This is low. PCO2 is 47. The normal is 35 to 45. This is high. Next, bicarbonate is 22 to 26. 28 is the result. It is high. So what do you think, okay, is this reading? The interpretation here, your answer should have been respiratory acidosis partially compensated, okay? So this must be respiratory acidosis partially, okay? Partially compensated. Partially compensated. Now, why is this interpretation respiratory acidosis? Because look, your PCO2 is high. Remember, if there's too much carbon dioxide in the body, the pH decreases. Therefore, it's respiratory in nature. The bicarbonate increases as a form of compensatory mechanism. Why is it important for bicarb to increase? Because bicarb is alkaline. Therefore, the bicarb will increase, trying to neutralize acidity. The problem there is the other system is trying to compensate by increasing bicarb but failed to normalize the pH. That is why the compensation there is not successful. The compensation there is only partially. Okay, so this is your partially compensated. So that must have been your answer. Okay, now what about here in your values, K, in your number 3? 7.38, that's your pH. The normal is 7.35 to 7.45. This pH is actually normal. Okay, now what about your PCO2? Your PCO2 is 31. The normal is 35 to 45. Therefore, it is low. Okay, now what about your bicarbonate? Your bicarbonate is 20. The normal is 22 to 26. Again, it is low. Now, we know for the fact that there's something wrong with the condition, because if this PCO2 is normal and bicarb is normal, then there is no issue. It is a normal ABG. But knowing the fact that PCO2 and bicarb has an abnormality and the pH is normal, so you know it could be a form of full compensation. And I said, if there is full compensation, your guide there is the mean of your pH. And again, the normal pH is 7.35 to 7.45, and the mean is 7.40. The question here, is 7.38 higher or lower than the mean? The answer, it is lower than the mean. Okay? It is lower than the mean. It is lower than the mean. Therefore, that should be in your brain. pH is lower than the mean, but within the range, 7.35 to 7.45. Okay? Now, if you're going to follow the steps I gave you and the algorithm, your answer should have been metabolic acidosis fully compensated. Okay? It should have been metabolic acidosis fully compensated. Fully compensated. Now, why it is metabolic acidosis? Remember, if you're going to cover your PCO2 and you check bicarb and the pH, remember your mnemonic, Romeo, respiratory opposite, metabolic equal, hydrogen opposite. Okay, if it is metabolic, the pH and the bicarb should be equal. Are they equal? Yes. Lower than the mean. Therefore, it falls under metabolic category. And it is acidosis because it is lower than the mean. So it's metabolic acidosis. What makes it full compensated? It is fully compensated because when the PCO2 decreases, it was able to normalize the pH. Remember, if there's an increase in the carbon dioxide, it causes acidosis. Therefore, the carbon dioxide here decreases in order to prevent acidosis, in order to normalize the pH. Then, because of that activity, a decrease in the carbon dioxide was able to normalize the pH or neutralize the pH. That is why, remember, I said for so many times that never answer fully compensated if the pH is not normal. You will only answer fully compensated if the pH normalizes. Okay? Now, what about in number 4? Look at your number 4. 7.35 to 7.45 is the normal pH. 7.49 is actually high. Okay? So again, if it is an increase in the pH, we call that a sure alkalosis. Am I right? Alkalosis. Now look at your PCO2 is 33. The normal PCO2 is 35 to 45. Here it's 33, therefore it is low. Okay? Now what about 29? Bicarbonate of 29 is high because the normal is 22 to 26. So it is high. Remember the steps in your ABG reading? The first step is to check the pH, and we were able to identify that the pH is alkalosis. Now, let's identify if this is respiratory or metabolic in nature. Let's try to cover your PCO2. If you cover PCO2, you check for bicarbonate and the pH, you suspect metabolic. If it is metabolic, these two must be equal. Are they equal? Yes, they're equal. Therefore, it is metabolic alkalosis. But wait, there's more. You try to cover bicarb. You check pH and PCO2. If you check pH and PCO2, you suspect respiratory. And if it is respiratory, that is, if your pH and PCO2 are opposite, that is respiratory in nature. Therefore, will it match the respiratory category? Yes. So this is also respiratory acidosis. Respiratory alkalosis. Okay? So what will be the interpretation for this problem? This problem is what we call mixed respiratory and metabolic alkalosis. Okay? So there is such thing in your ABG as mixed respiratory metabolic alkalosis or mixed respiratory metabolic acidosis. Okay, you won't get wrong on this. All you have to do is to follow the steps I gave you. Remember, the first step is to check the pH. After identifying the pH, the next step is you have to figure out if that is respiratory problem or metabolic problem. How will you know if it is respiratory? You check the pH and the PCO2, and these two must be opposite. How will you know if it is metabolic? You check the pH and bicarb, and these two must be equal. After you're able to identify whether it's respiratory or metabolic, the third and the last step is to classify whether it is uncompensated, partially compensated, or fully compensated. For this number 4, no such thing as fully or partially compensated because this is a mixed condition. Okay, so I hope you're able to get this correctly. So if not, then you go back to the previous video clip and try to figure out, analyze, understand, absorb all the things that I said there. Okay, so let's try to summarize the different acid-base imbalances I gave you. So let's talk about the different the different acid-base imbalances. Okay, so let's begin with what we call respiratory acidosis. Respiratory acidosis. Okay, so again, there are three categories: uncompensated, partially compensated, and fully compensated. So you have here your uncompensated, you have here your partially compensated, and you also have your fully compensated. Okay, so you have here your pH, so you have your PCO2, and you also have here your bicarb. If it is respiratory acidosis uncompensated, you will have a decreased pH or low pH, increased PCO2, but normal bicarbonate. If it is partially uncompensated, you will have a decreased pH, high PCO2, high bicarbonate. If it is fully compensated, you will have a normal pH, PCO2, and bicarb are elevated. Okay, so if you're able to understand my explanation from the previous discussion, previous video clip, you will understand this. Okay, so let's try to discuss respiratory acidosis. A patient with respiratory acidosis, the main concern is that there's too much carbon dioxide in the body. So if you're able to figure out what causes increased carbon dioxide, or we call that as your hypercapnia, those are causes of respiratory acidosis. Okay, so let's identify what causes respiratory acidosis. Number one, respiratory acidosis is actually related to what we call hypoventilation. Hypoventilation. Okay, remember I said when patient hypoventilates, the carbon dioxide cannot get out. The carbon dioxide stays in the body, and that will happen. What will happen? That will cause elevation of your carbon dioxide level. We call that as your hypercapnia. What causes hypoventilation? What factors can cause hyperventilation? Go back to your anatomy of fissure. Remember, the respiratory center in the brain is your medulla oblongata. So if you have any injury in the medulla, if there's depression in the medulla oblongata, maybe that depression is related to overdosage of your Heramoco. I hope you can still remember your Heramoco. That's your heroin, morphine, codeine. These drugs can cause respiratory depression. Okay, so number one, if you have depression, or shall I say injury in your medulla or medulla oblongata. Remember, this is the respiratory center. Next, another reason that can cause hypoventilation is that patient with stroke, okay, because of neurologic problem, patient with spinal cord injury, especially if it is a cervical injury or a thoracic injury, okay, that will affect the control of your breathing pattern, okay, respiration in general. So that can cause hypoventilation as well. What else? Another reason that can cause hypoventilation will be on the late part of a respiratory problem, okay? So a patient with respiratory disorders or respiratory problem on the later part will also hypoventilate, because initially, okay, during respiratory problem or respiratory crisis, you tend to hyperventilate because of anxiety, okay? And then eventually, if not treated, patient will what? Okay, will hypoventilate, okay? Next, another reason of hypoventilation is that patient having neuromuscular problem, okay? So all patient with neuromuscular disorders or disturbances will end up having pulmonary or respiratory disturbances as well. Give me an example of a condition said to be neuromuscular in origin that will end up having pulmonary problem. Okay? Example here is your Parkinson's disease. Remember, Parkinson's disease is a slowly progressive neurologic movement disorder wherein there's a decrease in what we call neurotransmitter called dopamine. Am I right? Remember that dopamine is a neurotransmitter, okay? Dopamine is a form of an inhibitory neurotransmitter for the muscles, but it is excitatory for the neurons, okay? The opposite of your dopamine is actually your acetylcholine. Acetylcholine is excitatory for the muscles, but inhibitory for the neurons, okay? But anyway, that's your Parkinson's. Another example of a neuromuscular problem is what we call myasthenia gravis or myasthenia gravis. If you can still remember what is this condition, it is a form of an autoimmune characterized by what we call production of antibodies that will destroy acetylcholine, okay? This is a condition that greatly affects the myoneural junction, okay? Anyway, go back to your neuro or you watch my neuro concept, you will understand this, okay? Another example of a neuromuscular problem is your multiple sclerosis. A multiple sclerosis is also another type of an autoimmune problem wherein it is characterized by demyelination of your CNS, okay? The partner of your MS is your GBS or Guillain-Barré syndrome. Guillain-Barré syndrome is also another type of demyelinative disorder or a form of demyelination but greatly affects your peripheral nervous system, okay? Now what else? Another example is your ALS or amyotrophic lateral sclerosis, which is a form of motor neuron disease. By the way, another name for ALS, amyotrophic lateral sclerosis is your Lou Gehrig's disease. Okay, I hope you can remember there is a scenario before. I forgot what year was that, where there's an ice bucket challenge that has something to do with your ALS. So if you notice all these neuromuscular problems, they will end up having pulmonary respiratory failure, and that is the most common cause of death. Okay, now another reason or cause of what we call respiratory acidosis is suffocation. Okay, once you're suffocated, it can cause respiratory acidosis. Okay, next, number 3, another condition related to respiratory acidosis is metabolic alkalosis. Remember, in metabolic alkalosis, there's an increase in the pH and there's an increase in your bicarbonate. That is why, remember I said, the two systems, if one system is affected or has a problem, the other system will compensate. Because you have an existing metabolic alkalosis, chances are you tend to hypoventilate, to induce respiratory acidosis, to bring down the pH. Why will you bring down the pH? Because in metabolic alkalosis, the pH is high. So you try to bring it down by causing hypoventilation. Okay, so let's proceed. A patient with respiratory acidosis, how do we treat patients like this? How do we treat this type of condition? Okay, please allow me to erase this part. So what will be our management for patient with respiratory acidosis? Let's talk about the drug of choice. The drug of choice for respiratory acidosis is actually your sodium bicarbonate. Sodium bicarbonate. If the type of acidosis is acute acidosis, we give IV sodium bicarbonate. If the type of acidosis is chronic acidosis, what we give is PO sodium bicarb. Okay? So if it is acute, we give IV. If it is chronic, we give PO. Highlight in your examination if it is a type of IV sodium bicarbonate. One of the most important nursing responsibilities is that before giving the medication, you have to check for the patency of your IV line and the placement of your IV line, because this medication is an irritant. It may cause tissue injury. Okay, next. Apart from this, because of what we call hypoventilation or alveolar hypoventilation, one management here is your respiratory support. So when I say respiratory support, that includes your O2 supplementation. And when I say O2 supplementation, it will also include your respiratory support, your mechanical ventilation. Why is it important to have mechanical ventilation? Because of condition hypoventilation. Am I right? So you need to do mechanical ventilation in order to maintain oxygen perfusion and oxygen supply. Okay? So these are common things you need to remember. Now, what about for your for the nursing action? One of the most important nursing action here, okay, is to promote carbon dioxide loss. So what will you do to promote carbon dioxide loss? All you have to do is to instruct patient to do pursed lip breathing. Okay? Do not forget that your pursed lip method of breathing, it means to say that you want to promote carbon dioxide loss. If you can still remember, your pursed lip method of breathing is just like blowing a candle. When you blow a candle, you have a longer exhalation, okay, in order to promote carbon dioxide loss. That is why if you be asked in your exam, what is the purpose of pursed lip method of breathing? Your answer there is to promote carbon dioxide elimination, okay? To promote carbon dioxide elimination because in respiratory acidosis, there is hypercapnia. So you want to get rid of carbon dioxide by doing pursed lip method of breathing, okay? The opposite of your respiratory acidosis is your respiratory alkalosis. Let's talk about respiratory alkalosis this time, okay? So please allow me to erase this part. So you will have your respiratory alkalosis, okay? So in your respiratory alkalosis uncompensated, you will have here, okay, you will have here an increase in the pH, but a decrease in carbon dioxide, and a normal in your bicarbonate, okay? If it is partially compensated, the pH is increased, PCO2 is low, bicarbonate is low. Why is your bicarb low? Because bicarb is alkaline. The moment you increase bicarb, then the more it aggravates alkalosis, the more it increases the pH, okay? If it is fully compensated, the pH is normal, PCO2 is low, bicarbonate is low. If you notice, all full compensation or fully compensated, they have a normal pH, okay? So let's talk about respiratory alkalosis. The main concern or main issue in your respiratory alkalosis is hypocapnia, or a decrease in your carbon dioxide. So if you can figure out, identify why do we have decreased carbon dioxide in the body, those are causes of your respiratory alkalosis, okay? So what causes this condition? The opposite of your hypoventilation. And what is that? Hyperventilation. So one reason there is your hyperventilation, okay? So why did the patient hyperventilate? What causes hyperventilation? What factors cause hyperventilation? Letter A is anxiety. Remember, if you're anxious, you hyperventilate, okay? What else? Fever can cause hyperventilation. What else? CNS infection can cause hyperventilation. What else? Patient who ingested toxins. So there's what we call ingestion of toxins. Hold on. Ingestion of toxins. So these factors may cause hyperventilation. Another cause of respiratory alkalosis is a condition called metabolic acidosis. Okay? In metabolic acidosis, there is a decrease in the pH and a decrease in your bicarbonate. Am I right? Give me a condition that is metabolic acidosis problem. Example is your DKA. Okay? Diabetic ketoacidosis. Remember, diabetic ketoacidosis is a complication of your type 1 diabetes mellitus. Type 1 common to type 1. Your type 2, okay, DKA is not common. What's common for your type 2 is your HHNK. Okay? HHNK stands for your hyperglycemic hyperosmolar non-ketosis. Okay? DKA is diabetic ketoacidosis. So if you notice in your signs and symptoms of your DKA, one manifestation of DKA is hyperventilation or your cosmos breathing. Why is it that patient with DKA hyperventilate? Hyperventilation is a compensation of the body if there's metabolic acidosis. Why? Because when you hyperventilate, you eliminate carbon dioxide. When you eliminate carbon dioxide, the carbon dioxide in the body decreases. As carbon dioxide decreases, the pH increases. Therefore, a patient with metabolic acidosis has a low pH. To increase the pH, metabolic acidosis, it induces hyperventilation as a compensation to decrease carbon dioxide in order to increase the pH of your patient. In short, hyperventilation is one action of the body as a compensation towards metabolic acidosis to increase the pH, because in metabolic acidosis, the pH is low. Okay? So the question here, patient with metabolic alkalosis, how do we treat or manage this type of problem? So what medications, what will be management for patient with with respiratory alkalosis? Look at your meds. Remember, one reason of metabolic alkalosis who hyperventilate is anxiety. So one medication there is your anxiolytic. Or shall I say, your sedatives. Okay? If this condition is related to fever, then we can give antipyretic drugs. Because of infection, you can also give antibiotics. Okay? So these are common medications given to your patient. Apart from that, you have to correct ingestion of toxins. Okay, I just want to emphasize something with your ingestion of toxins. The old answer is that if the patient accidentally swallowed an irritant, we induce vomiting. That's the old practice. Except if the thing swallowed is corrosive, we don't induce vomiting. That's the old practice. But now, do not forget this. Regardless whether it's corrosive or non-corrosive, we do not induce vomiting. What we do is we let the patient have sips of water. Small amount of water is okay, but we do not induce vomiting now. Okay? So please do not forget that. Next, number 3, another thing to remember. A patient with respiratory alkalosis, if the cause is metabolic acidosis, what will you do? So you have to treat underlying condition. Okay? So if the problem is DKA, then you do something about it. Okay? But nevertheless, one of the most important nursing responsibility here is to conserve carbon dioxide, to restore carbon dioxide. Will you tell the patient here to do per-sleep method of breathing? No, because the more it promotes carbon dioxide loss. So what we do here is to restore carbon dioxide. That is why, what will be our nursing action? Our nursing action is to tell the patient to breathe where? To tell the patient to breathe, through your cupped hands. Okay? Breathing through your cupped hands will promote, or restore carbon dioxide. The old answer was breathing through brown paper bag. Okay? There's an old answer, it's brown paper bag, but still okay. But at least you know there's an update. You can also breathe through your cup hands. So the reason why you do this, the reason why you breathe through your cup hands or breathe through your brown paper bag, the reason there is to restore carbon dioxide. I hope you get the difference. Okay, all the reason doing per-sleep method of breathing and breathing through paper bag or your cup hands. Okay, so that ends your respiratory acidosis and respiratory alkalosis. Let's proceed to your metabolic condition. Okay, so this time let's talk about metabolic acidosis. Metabolic acidosis. So in your metabolic acidosis, we still have these 3 categories: uncompensated, partially compensated, and fully compensated, right? So if it is metabolic acidosis uncompensated, what you will have here is a decrease in the pH, normal PCO2, and bicarbonate is low. If it is partially compensated, the pH is low, PCO2 is low, bicarbonate is low. If it is fully compensated, the pH normalizes, but PCO2 and bicarb are low. Okay? So remember, this is a form of your metabolic acidosis. Okay? But remember, we know that the pH is normal within the range, right? 7.35 to 7.45. It's just that the pH is less than the mean, less than 7.40. Okay, so let's identify what causes, okay, metabolic acidosis. Number one, metabolic acidosis, if you can still remember, is related to diarrhea. And by the way, metabolic acidosis is prevalent to children than in adults. Okay, next, number two. Another cause of metabolic acidosis is patient who have increased fat metabolism. Patient with increased fat metabolism. Now, give me an example of a condition with increased fat metabolism. Patient with diabetes mellitus. Okay, if you can still remember in your diabetes mellitus, normally is that if this is your blood vessel and these are your cells, normally if there's increased intake of carbohydrate, okay, when carbohydrate or sugar in the body increases, if there's too much carbohydrate in the blood, if there's too much sugar in the blood, that stimulates the pancreas, particularly the islets of Langerhans, to release a hormone called insulin. Remember, insulin is released in response to your hyperglycemia. But in diabetes mellitus, there could be no insulin, insufficient insulin, or there's a problem with your insulin receptors. Bottom line, the problem there is insulin. Okay? What is the relevance of your insulin? Your insulinerase serves as a key. Insulin opens the cell wall so that carbohydrate can get inside. If you don't have insulin, nobody opens the cell wall, carbohydrate or sugar cannot get inside the cell. That is why if you have diabetes mellitus, since sugar cannot get inside the cell, sugar stays in the blood, causing hyperglycemia. That is why one characteristic of diabetes mellitus is hyperglycemia. The question here is, why is it important for sugar, for carbohydrate to get inside the cell? Because sugar is a form of energy. Remember, when sugar mixes with your oxygen, that provides ATP or your adenosine triphosphate. That's the shortcut method. But nevertheless, it gives energy. Since you don't have insulin, no sugar can get inside the cell. Therefore, we can say that cells don't have energy now from your carbohydrate, from your sugar. So where will the cell get energy from? The cells now will get energy from protein and will get energy from fats. So if cells will utilize proteins and fats as a form of energy instead of carbohydrate, you call that phenomenon, you call that condition as your gluconeogenesis. Gluco, sugar is energy. Neo is new. Genesis is beginning. So there's new beginning of new source of energy. Okay? The problem there is increased fat usage. If you increase fat usage for energy, if there's increased fat metabolism, the byproduct there will be your fatty acids. Okay? And these fatty acid nurses will yield ketones. And these ketones can cause DKA. Remember with our topic a while ago? Respiratory alkalosis is induced by metabolic acidosis. So in your DKA or diabetic ketoacidosis, this is a form of metabolic acidosis. Okay? So anyway, let's continue. What will happen now if you have too much ketones? Too much ketones in the body, okay? Too much ketones now penetrate your blood-brain barrier, resulting to diabetic coma. Okay? Anyway, diabetic ketoacidosis is an example of metabolic acidosis. Okay? I hope you understand that. So these are two common reasons why you have metabolic acidosis. You have your diarrhea, you have your increased fat metabolism, and of course, another there is your respiratory alkalosis. So how do we treat patient with metabolic acidosis? How do we treat this type of problem? Same with your respiratory acidosis. So the management is the same with your respiratory acidosis. Remember, if the type of acidosis is acute, we give IV sodium bicarb. If the type of acidosis is chronic, we give PO sodium bicarb. Okay? I hope you understand that. Now let's proceed to the last topic. It's your metabolic alkalosis. So in your metabolic alkalosis, look, in metabolic alkalosis, the pH is high, bicarbonate is high, partially compensated, increased pH, increased PCO2, increased bicarb. Fully compensated, you will have increased PCO2 and increased bicarbonate as well. So what causes metabolic alkalosis? Metabolic alkalosis is related to frequent gastric suctioning or vomiting. Okay? So one reason there is vomiting. Another reason there is frequent gastric lavage or gastric suctioning. I explained this in video clip number 1. Okay? Another reason of metabolic alkalosis is bicarbonate overdosage. Okay? If there's too much bicarb given to your patient. Okay? Another reason of metabolic alkalosis will be respiratory acidosis, because remember, they compensate. Am I right? These two systems, they compensate. So the question there here is, how do we treat patient with metabolic alkalosis? What will be our management? If the type of metabolic alkalosis is mild metabolic alkalosis, it requires no treatment. If the type of metabolic alkalosis is severe, we give IV ammonium chloride. Okay? IV ammonium chloride is given to patient with metabolic alkalosis. Highlight in your examination. IV ammonium chloride is contraindicated to patient with hepatic problem or liver problem. Next, IV ammonium chloride must not be given fast drip. Not given fast drip. Question, why? What will happen if you give IV ammonium chloride fast drip? It causes RBC hemolysis. It causes RBC hemolysis. So what do you think is the ideal rate of your IV ammonium chloride if you cannot fast drip the solution? 1 liter must run over 4 hours. Okay? 1 liter must run over 4 hours, not less than 4 hours. Okay? Next, you have to identify what causes metabolic alkalosis. If the type of metabolic alkalosis is vomiting, then we have to give antiemetic drug. If you can still remember, you have your Zofran, your Ondansetron, you have your Compazine. Am I right? There's a lot of drugs, okay, that can control nausea and vomiting. What else? If the type of metabolic alkalosis is related to gastric acid loss because of frequent lavage or vomiting, that can cause also gastric acid loss, then we can replace that. So the medication given here is that we can give KCl, your potassium chloride, and then you have your plain NSS. Your potassium chloride and a normal saline solution, remember, you cannot give potassium chloride bolus. Am I right? It must be incorporated in your normal saline. The reason in doing this is to replace gastric loss. Okay? So these are common managements of patient with metabolic alkalosis. And apart from that, you have to treat the underlying cause. Okay? So if this is related to respiratory acidosis, then you do something about it. Okay? So this ends your acid-base imbalances, your ABG imbalances. So we were able to discuss respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. Okay? I taught you how to read ABG, the 3 steps and things to remember. Okay? I hope you learned something on this concept. And okay, if you have any questions or anything, feel free to drop a message on me or send a private message. God bless everybody and keep safe. Bye for now.